Hello, everybody. I hope you've had the chance to log in, and I look forward to discussing some of the aspects live with you tonight or on a recorded stream. My name is Andrew Cary. I'm a obstetrician gynecologist, but also a fertility specialist. I'm part of the Virtus Health group, and I'm part of Queensland Fertility group up here in Queensland, and I work at Queensland Fertility Group Gold Coast. And it's great to be able to give you this interesting patient information evening tonight, and we refer to this as all you need to know about fertility. So I've been an obstetrician and gynecologist for a number of years. I enjoy both helping women achieve their pregnancies through my fertility work, but also then helping them during their pregnancies. And I hope that this evening tonight, this discussion provides some valuable information for you, but also helps to answer some questions and send you on a path that will lead to you having success with achieving a pregnancy and achieving your family. And please feel free to drop in questions, and we'll endeavour to answer some of those questions as we go along. So I'm just going to share my screen now, which is of a PowerPoint presentation that is going to help to explain what we're talking about tonight. Okay, so we are here tonight to talk about all you need to know about fertility, and I anticipate that a number of you will have already embarked on this path a little bit further down the chain. But when somebody is planning fertility, they certainly have to be considering having their pre-pregnancy health or their pre-conception health as optimized as possible. That doesn't mean you have to become a saint and give up every enjoyment in life or sin in life, but it is sensible to reduce caffeine intake and certainly reduce alcohol intake, and ideally whilst trying to get pregnant, and then in pregnancy to drop the alcohol intake right down to nothing. A healthy diet is very useful, and this combined with exercise then leads one to a healthy body mass index. It goes without saying that we would advise ceasing cigarette smoking, and this is important for both pregnancy and pre-pregnancy, but also your long-term well-being. Now, when a couple embark on trying to achieve a pregnancy, each cycle going on, a certain number do achieve that goal, and it's probably around 15 to 20% of couples per cycle will achieve that conception. That doesn't sound like a very large amount, and certainly human reproduction is got some flaws, and so it's not inevitable that once you start trying to get pregnant that will happen. By the time a couple have actually been trying for 12 months, that 15%, 15%, 15%, 15% means that really 85% have achieved a pregnancy by the time 12 months have snuck by. But that essentially means that 1 in 6 couples are there not achieving a pregnancy, and that's the group that we refer to as subfertile. Now, so that means 15% or 1 in 6. Now, sometimes that's a female-related condition. Sometimes there's issues with regards to the anatomy. The tubes may be damaged or blocked, or there may be ovulation issues. There may be infrequent or irregular ovulation or difficult to time ovulation, or there may be no ovulation. Now, sometimes there's a male factor, and it's not uncommon. It's probably up to even 40% of the couples that are trying to achieve a pregnancy will not have success because of male factor. And not uncommonly, there's a combination. Sometimes we find that there is no obvious reason, and we would put this into the unexplained bracket. So we'll now move on and start discussing how we conduct our fertility consultation. So myself, as a gynecologist and a fertility specialist, receive a number of requests for consultations. And essentially, the first step is you need a GP referral to see a specialist within the Medicare system within Australia. So obtaining that GP referral is important. When we see you as a patient, it is ideal that we see both the woman and the partner. Most of the time that's a male partner, but as a same-sex couple, we still want to see the person planning to have a pregnancy and the partner. And we want to review the medical history. We want to review any past obstetric or gynecology history and fertility history. And then we assess general health and well-being. And at this consultation, we will start to plan some fertility testing. And in the case of the female, some of those tests can be performed at the time of consultation and at the bedside. And particularly here, I'm referring to the ultrasound scan. And we as fertility specialists and gynecologists and obstetricians, we have our bedside ultrasound that performs both transabdominal, but in particular transvaginal ultrasounds to be able to assess a major part of the anatomy, the uterus, within the uterus, the endometrium, within the uterus, the muscles of the uterus and looking for fibroids, and quite separate to this, the ovaries. And that's an essential part of our examination. And we will arrange hormone tests and other investigatory blood tests, such as infectious diseases screenings. Now, a very important test that we perform soon after the consultation is referred to as the egg reserve test, or the AMH. AMH stands for anti-Müllerian hormone, and that is a glycoprotein hormone that is released from ovaries, and it's released from the very small, what we call preantral follicles of the ovaries, the granulosa cells, which are cells of these follicles that give us a very strong indication of where somebody stands in their fertility reserve. Now, unfortunately, just about everybody who is going through their reproductive years, right from puberty right through to the later reproductive years and then approaching menopause, the fertility reserve is slowly, steadily dropping down. And the good news is that we have some concrete and constructive ways of at least giving us an idea of where you are on that curve. Do you sit up there at the 95th percentile, or do you sit there at the average? Or most importantly, are you in the unfortunate situation of being on the low percentile fertility reserve, where time is no longer a luxury for you in terms of achieving fertility? And so that AMH becomes a very important role. The sort of things we're looking for our female factors for subfertility? Could there be a tubal problem? Could there be even absent tubes from either previous surgery, ectopic pregnancies, blocked or damaged tubes? Or could there be an ovulation or egg release problem? Could there be any ovulation occurring? Could there be the condition called polycystic ovary? Polycystic ovary is very common and is related to menstrual disturbances with often prolonged and irregular cycles and sometimes no cycles. Often other symptoms such as increase in body mass, but not always present, and is an indication that ovulation or egg release is not occurring frequently or at a timely fashion. Now, other conditions are very important for us to look for, and some of these are listed there. Endometriosis and fibroids, part of our investigatory process. Now, from the male factor point of view, it's particularly concentrating on the sperm or semen. This particular graph that you see in front of you is quite an innovative experiment that will certainly never be reproduced in the future. This was a particularly keen scientist who dealt with in embryology, who did on a weekly basis for essentially 2 years his own semen analysis. And it demonstrates what a huge variation in semen numbers can be at any particular week or month or even year. And whilst there is tremendous variation, I think this scientist would have gone away feeling quite confident that except between the weeks of 65 and 85, he was probably well within the normal fertile range. But there is a variation. That's what this graph is meant to demonstrate. There is a tremendous variation in what sperm numbers are. But it's not just about sperm numbers. We look at those sperm numbers, but we particularly, our embryology scientists who are absolute experts at looking at these tiny motile swimming sperm, will assess them in terms of number, but assess them in terms of activity, or what we call motility, and most importantly, assess them in terms of their shape and abnormal shapes. They can have big heads, they can have small heads, they can have squiggly tails, they can have double heads, they can have double tails, they can have spinning tails, and all of those are very important factors, because it's only the best sperm, the highly motile sperm, the normal shaped sperm that are actually going to fertilize an egg. And there are other factors around the semen that are important, and there can be antibodies within the sperm that bind the sperm together that stops them from performing their job. And sometimes, even if there is normal sperm in the testes, there's not normal sperm in the male ejaculate because of some damage, blockage, or absence of the connecting tube, what we call the vas deferens. Other times there can be failure of sperm production. Sometimes that can follow cancer treatment. Sometimes that can follow anabolic steroids or bodybuilding type steroids. Sometimes that can follow from having a chromosomal variation or anomaly. So these are all factors that are analysed in the male. Now, once we achieve all of these investigations and results, a number have to go away to be tested. The AMH, the hormone tests, some of the infectious diseases screenings, the semen analysis. We can then come back and review those results and start to formulate a reason for subfertility. And of course, if we've got a reason for subfertility, then we can come up with a treatment option. we can create treatment plans. We can then start commencing treatment as soon as a couple are desiring to do so. Some of the treatments now we'll go into. First of all, the most simple treatment is to simply see when ovulation is occurring, maybe monitoring cycles, maybe just mapping the length of the menstrual cycle, knowing when the fertile window is, or maybe it is stimulating the irregular or absent ovulation to ovulate, and there is a medication that we refer to as oral fertility drugs to achieve that. The most common these days is one called letrozole, and then the second line therapy is called clomiphene. Both of these are designed to help to mimic in the very early phase of a cycle for the ovarian activity to take off, to then be ready, maybe around day 13, 14, 15, to result in ovulation. There are other ways to achieve these, but even with this simple version of ovulation induction, it still can come with some important monitoring to see that there is a response and the correct response. Now, if ovulation induction on its own is performed in a couple who've been trying for a year, their spontaneous natural conception chance after a year, if they keep just trying month by month, is only around 1%. If we add that fertility tablet in the right circumstance, that will boost that 1%, but it doesn't raise it up as high as what would be ideally optimal. It might raise the chance of getting pregnant to 5 to 10% at the very, very most. Probably closer to 5%, but then the next step on is the one in front of us on our screen now, referred to as in utero insemination. Now, in utero insemination is not for everybody. In utero insemination may help with unexplained infertility. Unfortunately, this slide says tubal disease, but in fact, it won't help with tubal disease. It's probably minimal help with endometriosis, and it's a particular area of frequent use in our fertility programs is with those women who are needing to use donor sperm. Now, the circumstances of donor sperm we will go into later, but they're typically either single women, same-sex couples, or in the circumstance where there is such severe male factor infertility that there is more or less no other option. Sometimes that's genetic, and sometimes that's because there is zero sperm count. In utero insemination raises the chance of getting a pregnancy per cycle. Once again, from that 1% of natural trying with no treatment to probably about 10 or maybe 12%. So we're improving the odds dramatically. And particularly single women or women in a same-sex relationship that in utero insemination of donor sperm carries with it a great chance of success. And that makes sense because in reality, they haven't had any areas of infertility as such before this, and they are simply using the treatment option of sperm. We move on then to look at the next area of treatment, and this is where it particularly becomes interesting. I'm afraid my computer isn't working those animations. So the animations were to show how we gently insert the donor sperm through the cervix. but we'll skip that little part now. Now, I have most of our further discussion will be about various forms and treatments of IVF and ICSI, but I'm keeping a little eye on the screen to see if there are any questions. Now, unless I'm having trouble sourcing those, but every once in a while I am looking, I don't seem to have any questions. So please feel free to type in questions. I think that's how it'll be obvious that they'll come up in front of me, but I'll keep on sourcing that. The rest of this discussion is going to center about IVF in our fertility unit and some other aspects of donor treatment. IVF, or in vitro fertilization, is fertilization of an egg with sperm outside of the body. That's what in vitro means. So it is fertilization that has had the opportunity to take place in our incubation dish in our laboratory. So the standard version of fertilization in the incubated dish takes place similar to the schematic over here on the left-hand side, where in an incubated dish, a healthy egg is then surrounded by healthy sperm, and a decent amount of them, to hopefully allow for one of those sperm to break down the barrier of the egg to then fertilize that egg. On the other side, on the right-hand side of the schematic, it demonstrates a version of this IVF that is referred to as ICSI or ICSI. ICSI stands for intracytoplasmic sperm injection. So that is where a sperm is specifically chosen by the scientist, and with the most minute of micropipettes is directly injected through the outer layer of the egg into the egg to enable fertilization. And that has been an absolute marvel of IVF technology that has now been around since the 1990s. So if we move on to how IVF and ICSI take place. First of all, our IVF unit is absolutely emboldened by the fact that our staff are the key to our successes with IVF. The fertility specialists are there to manage the treatment, but we absolutely rely on our ancillary staff. Our fertility nurses are highly specialized, highly trained, and they have such vast experience in all aspects of our fertility treatment that the patients find tremendous value in seeking their advice and their assistance. The nurses teach the patients how to run some of their cycles and how they give themselves injections. The fertility scientists are invaluable too, are also our fertility counsellors. Now, the step that is taken then of hormonal stimulation is the first step. Now, I've just got a question, and I'm grateful for that, so thanks for sending that in. Hello, doctor. What is the best treatment option for a couple trying to get pregnant naturally for more than a year with no known reasons for infertility? All reports for both male and female partner are okay. Female, age 33, male, age 38. Well, thank you very much for sending that in, and the person wanted to remain anonymous. Look, I hope I've explained in those few slides before, but in your circumstance particularly, there is no known factor that's causing your subfertility, but that doesn't mean, well, then everything's all right. It will be important to know where you sit with your egg reserve, and if the AMH is in an excellently high range, that gives you great hope for the future. But unfortunately, you really only have, statistically, once you've gone past that year of trying, you really only have a 1% chance of achieving natural conception per month. Now, that can still happen. I had a patient earlier today who came to me for her first discussion of fertility assessment. And as part of our first consultation, we performed an ultrasound. And I was absolutely thrilled, and so was she, although shocked, to know that she had a 6-week pregnancy. She was 6 weeks with a little teeny weeny fetal heart flicker. And that is fantastic. And she thinks I'm the best thing since sliced bread. But I didn't do anything. I just diagnosed the pregnancy. And really, that was a great chance and a great success, but 1% was her chance. But my suggestion to you, anonymous question, is you still need to seek advice, because 1% per month chance is not great odds, and you need to know how much time you've got and how much time you've got up your sleeve. And I'm sure you and your partner are keen to get started. Now, this getting started doesn't automatically mean we'll go all the way to the fancy IVF that we're going to talk further about. But thank you so much for that question. Now, we just will move on now, and we'll see, and I probably should now tick the box saying I've answered that question. There we go. Now, we're talking about how we go about an IVF cycle. Hormonal stimulation is crucial. If we didn't give hormonal stimulation, then we're really going to be, at the very most, finding ourselves collecting one egg at an IVF cycle. The aim of the hormonal stimulation is to make the ovaries want to produce a few eggs, each ovary, 2, 3, 4, 5, 6 eggs, and so that we can, at egg collection, be collecting a cohort of eggs that gives an excellent chance of success. In the process of doing that stimulation, there's got to be monitoring of blood tests or hormone tests, and monitoring by ultrasound. The hormone tests give steady rises in the hormone called estrogen, but we're also looking on ultrasound for follicle numbers and follicle growth. And then at the right time, the fertility specialists such as myself or any of my colleagues will do what is referred to as a transvaginal oocyte retrieval or egg collection. And that is a procedure. And we'll show you on some diagrammatics in a few seconds, where we very gently, under ultrasound guidance, and usually with some form of either pain relief, as in significant analgesia, or anesthesia, so a light anesthetic or significant pain relief, we collect eggs from the vaginal ultrasound guidance. Back in the lab, the scientists then will be taking those eggs that have been assessed as good quality or mature, and they'll be fertilizing by those earlier techniques of fertilization we talked about. In the lab, those embryos are then grown on in incubators. They are grown on to day 5 or to day 5 or day 6, when they can then be either transferred or they can be frozen. So we'll cover some of that on another slide. Now, I'm afraid I have to sneak away from those diagrammatics, but this slide now demonstrates how an embryo would look under the high-powered microscope. So our embryologist scientists are very adept and clever at assessing eggs, sperm, and embryos. And these are a few micro photographs, however we might call it, micro photographs of a fertilized egg and how it grows into an embryo on day 2 and 3, what we refer to as cleavage stage. Then on day 4, a morula, and on day 5 or beyond, day 5 or day 6, as a blastocyst. Now, it's usually at the blastocyst stage that embryos are either transferred or frozen, and we'll explain that. So when somebody goes through an IVF cycle, if we get that number of 4 or 5 or 6 eggs from each ovary, we're hoping to end up with around 10 to 12 eggs. If we get 10 to 12 eggs collected in the operating theatre, the scientist is there with us at the time at the egg collection bedside and telling us there's eggs, and then they then assess those for which are good quality. Are they all good? Are they all mature? No, they won't be, but a number of them are. And then those mature eggs are then taken in the incubation setting to either be fertilized by standard IVF or fertilized by ICSI to then create embryos. Now, at that stage, there's a slow, steady drop off. You've started with 10 or 12, you're down to a few less. And then by this stage, we wanted to see that fertilized egg is what we call dividing or becoming a 2-cell, a 4-cell, an 8-cell, and then on to morula and blastocyst. So once we see that the embryos are developing and dividing, we then have the opportunity, and typically in most of our IVF units, it's around day 5 or 6, that we transfer an embryo. Very, very typically and almost universally in Australia and in a lot of other major countries around the world, it is one embryo nowadays that is transferred. And that's a very important step because we are at the most going to transfer either one embryo or 2 embryos. And the aim is we're trying to give you a healthy pregnancy. A singleton pregnancy is ideal, not trying to create high order multiples. So we're transferring one or at the most 2 embryos, and then that leaves the opportunity, hopefully, that there's still a cohort of perfectly well healthy embryos to freeze, and then those frozen embryos become chances of preservation, chances of success later on. So next we will go to the next slide, which talks about the embryo transfer process. Now, there's a lot of technology that has gone on up until this stage to achieve our embryo. We've done hormonal stimulation, we've done monitoring with hormone tests, monitoring with ultrasounds, monitoring and then collecting of the eggs at more or less a minor procedure. It's not an operation as such, but the egg collection or egg retrieval is in the operating theatre complex. Now, those embryos have been nurtured in the laboratory, and the embryo transfer is a relatively simple process compared to a lot of the other steps that have gone on before. But the embryo transfer, whilst relatively simple, is extremely crucial because we want to guide an embryo that's taken from its incubation chamber and very quickly placed inside the womb so it can then continue to incubate, but in the natural environs of the uterus. So we have to guide the embryo like doing a speculum examination at pap smear. We see the cervix, we cannulate the cervix, and then the embryo transfer catheter comes through that cannulation so that the embryo is placed gently and neatly into the important environs of the endometrial cavity, or the lining of the womb, and is then released so that it can then implant. Now, this procedure is really important, but it doesn't take very long, and it's not terribly high tech. And there can be then a return to normal activity very, very quickly. Once that has been performed, then that cycle is already then on its way to hopefully success. What happens with the remaining embryos? The good quality embryos are assessed to see that they are also of suitable quality to achieve a pregnancy, and the ones that are then rapid freezed by what is called vitrification. And we can rapid freeze embryos at earlier stages, but the majority of embryos are rapid frozen at day 5 or day 6, or what is referred to as blastocyst. And those embryos, in reality, can remain frozen for a long time. The requirements within Australia are that they can be frozen for up to 10 years. There has to be decisions made within that 10-year program, is basically the rationale. And the benefit of that is that creates a fertility preservation for any particular woman or couple, that they can then turn back to achieving another pregnancy by one of those frozen embryos. One of the challenging things after we've done the embryo transfer is the 9 to 10, it says 10 to 14 here, but it's about a 9 to 10 day wait after an embryo transfer. We wait until we're going to prove that a pregnancy has started, and that's with a pregnancy test, which is usually a blood test because that's the most accurate. And that's a challenging time because there's not a lot of involvement with the fertility staff. They're happy to provide some assistance and counselling and discussions, but there's no action that's taking place then. We're waiting that time. Now, where does all this lead to? Well, remember we talked about that a couple trying who haven't got a pregnancy for more than 12, who've gone over 12 months, they have about a 1% chance of natural conception. Well, IVF, it would be magnificent if it went to 100%, wouldn't it? But it doesn't. The chances of success with IVF in Australia are as good as they are anywhere in the world. And we're very pleased to say that the chance of success hovers between about the 30 to 40% range in terms of achieving a pregnancy per fresh embryo transferred. And then, unfortunately, there is always a drop-off from pregnancy to chance of delivering a live baby. And it's delivering a live baby that most people are really interested in. In our heart of hearts, we're wanting to hold that baby in our arms. And the chances of that are around that 30% range. Now, this graph shows that, in fact, there are excellent chances of success in the 20-year-olds and in the early 30-year-olds. But then the chances of success do drop off. But even in the 35 to 39-year-olds, there's still a very good chance. But then the drop-off becomes more dramatic for those 40 years of age and above. And as you can see on this graph, if you've gone beyond age 44, the chances of a pregnancy and a birth at age 45 or above is more or less zero. And that's with your own eggs and fresh embryos. If we click to the next slide, you see that things are a little bit different. It's still excellent. So there's a few take-home messages from this slide. Firstly, frozen embryos do extremely well. Frozen embryos transferred have an excellent chance of producing a pregnancy and producing a baby. And that's at a number of age groups. It also drops off. Everything drops off with age. But it's important to see that women in their 40s do have an excellent chance of having their pregnancy and having their baby from any frozen embryos. Now, there's a couple of very important issues here. One is that at age 45 and above, there's still an excellent chance of pregnancy from frozen embryos. Now, there's really a couple of reasons why. Why would this be when it was 0% for a fresh embryo? Number one is those embryos frozen may well have been eggs collected at a younger age, first of all. Number two, they may be eggs collected from other egg donors. So that's also a very important part of the equation. And that leads us to be really confident that frozen embryos do extremely well. Frozen embryos are a major part of our fertility programs here at our IVF unit at Queensland Fertility Group, all through Virtus, but all through Australia and really all around the world. Frozen embryos are not the second class embryo. They're not embryos that is a second choice. They're excellent prospects for achieving a pregnancy and also giving fertility preservation. And particularly in that circumstance where a frozen embryo may have come from an egg collection 5 or 8 years ago, when the chances of success is always related to the age, and it is the age of timing of egg collection. So our advanced technology of assisted reproduction technology, of IVF and ICSI and all the other things we do, enables us to select good quality eggs. In the case of ICSI in particular, select the best sperm. What that leads the scientists to be able to do is then fertilize those eggs with sperm to select the best embryos. There is other technologies that can be added to value add to selecting the best embryos. Number one is doing pre-implantation genetic testing of embryo biopsies to check the genetics of an embryo. Number two is the new, quite highly used, frequently used now, technology of the embryoscope, where embryos are then in a time-lapse imaging closed condition of an incubator that no longer has to be assessed day by day. There can be time-lapse imaging of the embryo through its development, and there is then the added availability of being able to use artificial intelligence to score those embryos under time-lapse imaging to see where they fit into the chance of success and the chance of a healthy delivery. This is all leading, and all of these versions of technology leading to, for us at our IVF unit, to be able to provide the best chance for people to achieve a pregnancy and, more importantly, to achieve a healthy delivery. So that then leads on to what other things do we do at our IVF unit. There is part of our IVF program is about donor That's gamete donation, as we call it. That's sperm donation, egg donation, also embryo donation. And then there is also the area of surrogacy. The donor program is very important. It's essential, obviously, for same-sex couples and for single women to achieve pregnancy with the use of donor sperm. Women who can't produce their own eggs, whether they've had their ovaries removed or whether they've got absolutely zero egg reserve, there's the opportunity of egg donation. And of course, when a couple who have gone through IVF have completed their family but have other embryos frozen, it is a fantastic gesture if they can bring themselves to donate those embryos to other couples who haven't had the opportunity to have success. Surrogacy is a rapidly growing area. So surrogacy essentially refers to a couple who are going to be the recipient of a child who can't carry a pregnancy themselves for whatever reason, whether the uterus has been removed at hysterectomy, or whether the uterus is of such a inappropriate or hostile environment that it can't carry a pregnancy, or whether there are medical major complications to carrying a pregnancy, that the pregnancy has to be carried so that the child, which is fertilized typically by the recipient's own eggs and the recipient's partner's own sperm, for that pregnancy to be carried by somebody else, that is a fantastic gesture that then allows for a pregnancy that then a baby can be delivered, and then the recipient parents will then be able to have their own child. Donor program is crucial to us, and sperm donation is probably the major part of that donor program. It, as I say, is an excellent option for our same-sex couples and single women, but also where there is major male factor infertility of zero sperm or genetic reasons, whether that's a gene defect such as cystic fibrosis or spinal muscular atrophy, or whether that's another genetic condition such as Klinefelter's, where there is no sperm produced. There are a number of reasons why couples would head down the path of using donor sperm. Sperm donors are gold to us. They are happy to donate, but they need to undergo medical testing, genetic screening, counselling before donation can occur. And then sperm is collected, assessed, quarantined, and then there has to be further infectious diseases screenings to make sure that that sperm is completely safe for the recipient woman. And the option with regards to the use of donor sperm is depends on the circumstances of subfertility, but sometimes that's just in utero insemination, like I mentioned earlier in my discussion, and other times it's with IVF in the form of ICSI. Same-sex couples have the other unique availability where both couples, both participants in the relationship have ovaries, and frequently both have uteruses. So there can be egg sharing, and there can even be uterus decisions about who collects the eggs, who carries the pregnancy. So these are all things that we deal with in our fertility program. Another area of our fertility program, which is really quite interesting and exciting for those who need it, fertility preservation. Now, one of the most challenging areas of fertility preservation is the patient who arrives very quickly, having had the devastating diagnosis of a medical condition, typically cancer, that requires some very intensive therapy that may well mean that future fertility will be hampered, whether the ovaries will be rendered incapable of future egg release because of chemotherapy or radiotherapy, or whether there's other treatments. But we're frequently collecting eggs for fertility preservation from these women. Sometimes that's fertility preservation from, and very commonly, in fact, fertility preservation for the male who's having his sperm collected before it undergoes treatment for testicular cancer. There are other reasons for fertility preservation, and a woman may decide, for whatever reason, career, studies, finance, or whatever, to delay having her children until later years, but knows that her egg reserve is going to fall and wishes to have eggs collected and therefore preserved. Now, the best pregnancies come, in fact, from frozen embryos rather than frozen eggs. But if we are freezing eggs, they are best from the younger patient. So some couples doing fertility preservation, it's all very simple. They've got both the male and female couples, so they can have eggs collected, fertilize those eggs with the sperm and freeze the embryos. Others, it's a decision that needs to be made quickly where they freeze eggs, and all of that can be accommodated in our IVF unit. So with all of these discussions tonight, we've focused on all the things we can do as IVF specialists. Now, I'm proud to be a fertility specialist at Queensland Fertility Group on the Gold Coast. I'm part of the statewide unit of Queensland Fertility Group. I'm part of the nationwide unit of Virtus Health. And the good thing about that is that here I am locally in my Gold Coast office, and all of our facilities are in our Gold Coast setting in this one building that I'm sitting in right now. Our local fertility specialist care is here. We've got all our local nurses, our local scientists. Our egg collections are done in our building, and our ultrasounds and our consultations are done right where I'm sitting now. But we also have, beyond that, all of the fertility services available through Queensland Fertility Group and Virtus Health. And that means a lot of the genetic testings that can be done elsewhere, higgledy-piggledy, but is all done in-house in our fertility unit. So I'm so pleased to be able to offer that to our patients on a regular basis. Now, I believe that we've come to the point where I think I've discussed enough. I think it's important, as I said right at the beginning, that if you're a person or a couple who are keen to explore your fertility options, that you should be getting referrals from your GP to come and see one of us as specialists, and then you'll be able to advance your plans. Now, I just got to work out if we've got any other questions on our list here. And I'm having trouble looking on here. So as far as I can see, there is, we do have some other questions, and I've just found a whole new category. How about that? Does stress cause infertility? And I think that's a really important thing to consider. There's no doubt that fertility treatment and the whole process of fertility is stressful. We would love to say that we're going to alleviate all the stresses associated with fertility treatment, but that isn't the case. And our fertility nurses, our counsellors, particularly the counsellors, are designed to try and minimise that. And stress does affect fertility. A number of people find that they go on a holiday and they get pregnant. And clearly that's not because it's easy to get pregnant in the tropics up at Hamilton Island or Cairns, but there are factors about our daily stresses that are having an effect, and we try and minimise that. Some people turn to acupuncture, some people turn to meditation, but whatever you can do to minimise stress, that's useful. Now, what is the best treatment to use if both my partner and I have no fertility issues apart from my tubal ligation? Well, that's a really good question too. The good news about that is that presumably the tubal ligation was performed after having a child or two or more. And so we know there's proven fertility. If somebody comes along after they've had 2 children or 3 children, they've had their tubes tied and then they want to change their mind. Well, the absolute answer to that is IVF. If the tubes are tied or blocked, then trying to rejoin those doesn't have a great chance of success, and it increases the risk of tubal ectopic pregnancies, whereas IVF means you can collect those eggs, don't have to worry about the tubes. We're fertilizing in the laboratory, and then we're placing an embryo via the cervix into the uterus. The tubes no longer become part of the function. So that's an excellent solution for that. And that also applies for the patient who has the husband having had a vasectomy. You can reverse the vasectomy, particularly over the first couple of years, but the sperm function reduces the longer the vasectomy has been in place, and sometimes it is better to go to the version of IVF called ICSI, where we collect the sperm directly out of the testes at a minor procedure, as well as collecting the eggs. Another question is, does an arcuate uterus affect fertility? And if it does, what can be done? Well, there's a few aspects of uterine shape and distortion of shape that do affect fertility. And fortunate that a large number of women don't even know they've got a misshapen uterus until they've achieved pregnancy, and then the pregnancy grows in what we call one particular horn or direction inside the uterus. Now, but a uterus with a septum in the middle, a distortion of the uterine cavity, does reduce the chance of implantation, and therefore correcting that, and that's a procedure we do as gynecologists to shave back that septum inside the uterus to improve the shape of the uterus and to maximize the chance of implantation. So they're all great questions, and I appreciate those inputs. So I am hoping that we've explained a lot of what happens with our fertility treatment. Just clicking back on here, there's 2 areas that I have to look at for questions, so I keep going from one to the other. Do PPL with unexplained infertility have higher chance of having do people with unexplained infertility have a higher chance of having a baby with IVF? Yes. We have those categories of reasons for fertility. There's female factor, that's ovulation issues, tubal issues, sometimes endometriosis, they're the most common ones. Male factor about the sperm function. And then combined, and then there's that group who are unexplained. Now, there is still that same statistical answer there, that even when you're unexplained infertility, you've really still only got about a 1% chance of getting pregnant per cycle if you just head along the same path of natural. If you do IVF, that typically boosts that right up there to a very high chance. It's often nice to be able to say it was tubal or it was sperm function, because you know that IVF is automatically going to take care of tubal issues. ICSI is automatically going to take care of sperm function issues, but even unexplained has an excellent chance of pregnancy with IVF. So great question. Okay, I think I've sussed out where all of these questions now lie and hide, and I'm hoping that I have provided some very useful input to you, and I'll check there, and I'll check on my phone for any final questions. And there is another one here that says, what is the best treatment for a tubal ligation? Well, in my hands, I believe that the best treatment for achieving a pregnancy following a tubal ligation is to do IVF. There is the opportunity to have what is referred to as tubal microsurgery, but there are now only a few subspecialists throughout Australia who truly do that well microsurgically. And there are a large number of units throughout Australia who do IVF extremely well. And the benefit of doing IVF is you've often got that opportunity to collect the eggs, create embryos, and to freeze some embryos. So even if the treatment didn't work the first time, or even if you've had one pregnancy and you've still got further frozen embryos, you can still have another. So, so that's a very good solution. Well, I think we've covered a lot of information tonight, and I so much appreciate those questions to provide a little bit more interaction. And I hope this has stimulated some thoughts with you. And I look forward to hearing from some of you and seeing some of you as patients. But please remember that there are solutions to your fertility issues, and I hope we've provided some input into that today. I think we can probably call it a day, and so we'll probably now work out how to close this off, and then we can get on with our evening. So good night, everybody, and thank you for participating.